Good evening, Dr. Kedar, sir. Dr. Sameer is also there with us. So we'll just start with the session. So on the behalf of West Zone NOEL, I invite all the faculty members as well as the attendees for this session on retinopathy of prematurity. We have chosen this topic because this is a topic which is always read in the books but least discussed. So we thought of discussing this as a part of seminar with a smaller case presentation by Dr. Poonam. So we have with Dr. Poonam Sawant, who is a fellow at Motherhood Women and Children's Hospital in Mumbai. And this further, a 20-minute seminar session will be followed by a discussion by our moderator, Dr. Sameer sir, who is a consultant neonatologist at Eona Newborn Hospital and Ma Fertility Center in Mumbai. And we have two great experts with us. Dr. Anand Vinekar sir, he's a head of the department and program director, Kid ROP at Narayana Netralaya Eye Hospital, Bangalore. We welcome you, sir, and very grateful to you. We have heard a lot about you and a great fan of yours. So we welcome you for this session, sir. And we have with us our own Dr. Kedar, sir, Director, Deogiri Children's Hospital in Samji Nagar. So welcome you, sir, for the session. Over to you, Sameer, sir, and we can start with Dr. Poonam's session first. So yes, Dr. Poonam, you can go ahead.
Okay. Good evening, everyone. Today we'll discuss retinopathy of prematurity. Next screen now. So ROP is the arrest of normal retinal, neuronal, and vascular development. It is a pathological vasoproliferation of the retina and a preventable cause of blindness. The normal retinal vascular development. Human retina contains of 5 cell types from the vascular complex: the vascular endothelial cells, astrocytes, microglia, pericytes, and complex of 3 cell types, that is the neuronal substance P containing cells, nitric oxide synthase containing, and dopaminergic amacrine-like cells. The role of cells in normal retinal development. The astrocytes, which are immunoreactive, are involved in the process of vasculogenesis. These are the highly sensitive to hypoxia, and under conditions of low oxygen saturation, they release VEGF. Now the phases of ROP. First phase is the vasoobliteration of the retina. In this relative hyperoxia of the extrauterine environment as compared to the intrauterine one, there is vasoobliteration, non-vascularization of some areas of the anterior retina. And in the next phase, that is the proliferative phase, subsequent hypoxia results in vasoproliferation, leading to involution or permanent cicatricial changes and further visual impairment. This is the diagrammatic representation of the postnatal phases. Phase 1 is the vessel, whereas the vessel growth stops because of the decrease of the growth factors. And in phase 2, because of relative hypoxia, there is increase in all these factors, leading to retinal pathological vascularization. Next slide, please. In the phase 1, hyperoxia is an important driver for the arrest of vascular growth. It leads to the suppression of oxygen-regulated angiogenic growth factors, erythropoietin and VEGF, which leads to cessation of vessel growth and poor development of the vessels. In phase 2, there is increasingly metabolically active phase, but it is poorly vascularized retina, so it becomes relatively hypoxic. It is characterized by the proliferation of blood vessels, largely in response to hypoxia-driven increase in the VEGF and erythropoietin. Now, pathophysiology. The neovascularization is pathological, so it poorly perfuses the retina. The vessels are leaky and it leads to fibrous scar formation and retinal detachment. The transition between phase 1 and phase 2 depends on the post-menstrual age and not the postnatal age. This is again the diagrammatic representation of the pre-phase, that is sensitization in utero, and in the extrauterine phase, the phase 1 and phase 2. Next slide, please. Now, etiology of ROP. Prematurity is a very important risk factor. Then oxygen exposure, saturation fluctuations, inflammation, and other factors are genetic, socioeconomic, and dietary factors. Now, oxygen saturation target range for extremely preterm infants. There were trials on this, the 5 trials which formed the Neoprom meta-analysis. The comparison between low SpO2 targets and high SpO2 targets, that is 85 to 89% versus liberal targets 91 to 95%. The liberal oxygen target had significantly lower mortality and less NEC before hospital discharge. And in some trials, it was seen that there was increase in risk of severe ROP with high saturation targets. There was no difference in BPD, neurodevelopmental, and hearing outcomes. Now, birth weight and gestational age. In preterm infants, as compared to AGA infants, small for gestational age are more prone to ROP. Next slide, please. IGF-1 and postnatal weight gain. In babies born preterm, there is a strong association between early postnatal low serum IGF-1 concentrations because initially they get it from the mother and later on it is cut off. IGF-1 acts as a permissive factor for VEGF, dependent vascular endothelial growth, and IGF-BP3. Other factors are hyperglycemia, insulin, and nutrition. Raised neonatal glucose concentrations, there is a high risk for ROP, and increased nutrition and adequate IGF-1 concentration seem to be necessary for postnatal growth and the reduction in the risk of ROP. Now, ROP burden. In case of preterm infants, there is 50% infants weighing less than 1250 grams at birth show evidence of ROP. About 10% develop severe ROP. Incidence in India is around 20 to 30% of screened neonates. And as per gestational age, less than 28 weeks, there is severe ROP. 28 to 32 weeks, moderate ROP. And above 32 weeks, there is milder form of ROP. Now, this is an international classification of ROP. It takes into consideration the zone of the ROP, that is position, whether anterior or posterior location of the vascularization, severity, that is the staging, and extent of ROP in clock hours. These are the zones. Next slide, please. I'll explain the zones. Zone 1 is a circle with optic nerve at the center and a radius of twice the distance from optic nerve to macula. Zone 2 is a circle whose radius is the distance from center of the optic disc to the nasal margin of the retina, that is ora serrata. And zone 3 is the lateral most crescent-shaped area from zone 2 to ora serrata. Extent of involvement is expressed as clock hours, 12 clock hours, 30-degree sectors each. Next slide, please. This is the ICROP classification. This is the third edition, 2021 classification. In this, stage 0 is incomplete vascularization, no ROP. Stage 1 is thin white line of demarcation between vascular and avascular area. Stage 2 is ridge in between the vascular and avascular area. The white line increases in width and height. Stage 3 is the ridge with extraretinal neovascular extension in the vitreous. Stage 4 is partial retinal detachment. In that, there is 4A, which is without foveal involvement, and 4B with foveal involvement. Stage 5 is total retinal detachment. Stage 5 is again subdivided into 5A, 5B, and 5C. In 5A, there is optic disc funneling. That is open funneling. It is visible by ophthalmoscope. 5B, that is optic disc closed funnel. And 5C is stage 5B plus anterior chamber abnormalities like shallowing, lens displacement, etc. Now, these are the images of the stages. Here we can see a white line of demarcation. Next. This is the ridge formation. This is the extraretinal fibrovascular proliferation in the vitreous. And stage 4 is the partial retinal detachment. Stage 5 is complete retinal detachment. Now, pre-plus disease. There are vascular abnormalities of the posterior pole that are insufficient for the diagnosis of plus disease. There is arterial tortuosity and venous dilation, which is more than normal. This is the image of the pre-plus disease. Next. Yeah, these are again the stages of international classification of ROP. Next. Now, plus disease. It is the presence of venous dilatation and arterial tortuosity of posterior retinal vessels in at least 2 quadrants, and it is associated with vitreous haze, pupillary rigidity, and iris vascular engorgement. There can be vitreous hemorrhage as well. Next. So, first image is a normal image, and second shows plus disease, increase in the tortuosity. Now, aggressive posterior ROP. It is a rapidly progressive severe form of ROP, that is a rush disease. It progresses to stage 5 ROP if untreated. It is posterior in location zone 1 or zone 2 plus disease and is ill defined with a classical bridge. And it can skip the stages and it can directly progress to stage 4 or stage 5. So it is more dangerous. It is characterized by ischemic loops, capillary non-perfusion, and a flat intraretinal network neovascularization. And the innocuous look of the retina can get missed. Now, types of ROP, type 1 and type 2 ROP. Type 1, it denotes a disease that must be treated and includes stages 1, 2, or 3 in zone 1 with plus disease, stage 3 in zone 1 without plus disease, and stage 2 or 3 in zone 2 with plus disease. So it is a more severe form and needs to be treated. And type 2 is zone 1, stage 1 or 2 without plus disease, and zone 2, stage 3 without plus disease. The late phases are spontaneous or after treatment phases. There can be spontaneous regression, that is disease involution and resolution with complete vascularization, or it can be incomplete with persistent avascular retina. There can be a phase of reactivation even after a spontaneous regression or treatment, that is the recurrence of acute phase features. And long-term sequelae is late retinal detachment, retinoschisis, lattice-like changes, persistent avascular retina, retinal holes, macular abnormalities, or abnormal foveal development. Now, which babies to screen? The babies which are less than equal to 34 weeks of gestation, the babies less than equal to 2000 grams, and 35 to 36 weekers with risk factors like the need of cardiorespiratory support, prolonged oxygen, apnea, anemia needing blood transfusions, neonatal sepsis, RDS, CLD, fetal hemorrhages, exchange transfusion, or IVH. And even the term babies with a very turbulent NICU course have to be screened. Next. Now, what is the screening window? The median age at the detection of stage 1 ROP is around 34 weeks. In Indian context, it can be detected even before 32 weeks of postmenstrual age, and it can occur earlier than 2 weeks of postnatal age as well. Vascularization is usually complete by 40 to 44 weeks of gestation, and the crucial period for detection is from 32 to 40 weeks of postmenstrual age. Next, when and how often to screen? The baby should receive first screening at 4 weeks of birth or by 31 weeks of gestation, whichever is earlier. Infants with period of gestation less than 28 weeks or less than 1200 grams should be first screened at 2 to 3 weeks after delivery. And this is to rule out aggressive posterior ROP. And it should not be delayed maximum beyond 30 days of life. In general, the screening examinations will usually continue every 2 weeks until vascularization of retina reaches completion or until the ROP regresses and there are no signs of visual loss. It normally happens around 40 to 44 weeks until ROP requiring treatment develops. And this can be subjective as per the findings during the screenings. What happens if it is not screened on time? It can progress to advanced stages. There can be retinal detachment and permanent irreversible vision loss or strabismus. Now, follow-up schedules. These are to be advised by the ophthalmologist, which is screening for ROP. In 1 week or less, follow-up is advised in cases of stage 1, 2, or 3 ROP in zone 1 and stage 3 ROP in zone 2. 1 to 2 weeks follow-up in case of immature vascularization zone 1, that is no ROP, stage 2 ROP zone 2, and regressing ROP in zone 1. This is the same, the follow-up schedule. In case of zone 3 ROP, 2 to 3 weeks gap can be taken before rescreening. Now, how to dilate the pupils before screening? Pupils are dilated with phenylephrine 2.5% and tropicamide 0.5%. One drop of tropicamide is instilled every 10 to 15 minutes for 4 times starting 1 hour before the examination. And if the pupils are not dilating despite adequate mydriatic drops, it can be a sign of APROP. It should be suspected and visualized likewise. Examination. It involves indirect ophthalmoscopy, 28 to 30 diopter lens. After instilling topical anesthetic drops like proparacaine, wire speculum is inserted to keep the eyelids apart. First, the anterior segment is examined, followed by posterior pole, and then the sequential examination of the peripheral retina. Examination is to be kept as brief as possible, and measures to alleviate pain and proper recording of the findings is to be done, and follow-up guidance is to be given. This is the newer technique, that is use of wide field digital camera, that is a red cam. In this, trained nurses can take the retinal images in preterm infants, and these images can be sent to experts for their reviews to analyze them, and it can even be documented. Now, treatment of ROP. Cryotherapy is obsolete now, it is no longer used. Laser, anti-VEGF, and vitreoretinal surgeries in case of advanced stages like stage 4 or stage 5. Indications of active peripheral retinal ablation. So type 1 ROP, it is an indication for retinal ablation, and type 2 ROP, we can wait and watch for progression and regression. Now, laser treatment. It includes the diode double frequency YAG laser. Both eyes can be treated in the same setting unless contraindicated by instability of the baby. It is to be done under monitoring, and post procedure also the baby is to be monitored for 48 hours. Follow up in 5 to 7 days. Anti-VEGF drugs. The intravitreal anti-VEGF drugs like bevacizumab or ranibizumab, when directly injected in the vitreous chamber, cause regression of abnormal vessels without destroying the peripheral retina. When to prefer the anti-VEGF drugs as compared to laser? In case of posterior diseases where laser is not possible, when ROP is relatively more aggressive, because anti-VEGF directly binds to the VEGF and inactivates it. So the action starts in 12 to 24 hours, as opposed to laser treatment where the action starts late. The three anti-VEGF drugs used are bevacizumab, ranibizumab, and aflibercept. Advantages of anti-VEGF. It is faster to perform with minimal sedation and quick recovery of the baby to the baseline. In case of beta ROP trial, it was noted that there is lower incidence of high myopia at 2.5 years of age as compared to laser. Side effects of anti-VEGF. It has a significant systemic absorption. Hence, there are concerns regarding lung growth and brain development because the angiogenesis is affected. And iatrogenic complications because of injectable like cataract and endophthalmitis can occur. Reactivation rates are more. Hence, laser treatment may be eventually necessary. Now, the prevention strategies. Primary, secondary, and tertiary prevention. So, primary prevention is prevention of preterm birth, in situ transfer of preterm babies in a setup where there is a NICU, antenatal steroids for threatened preterm delivery, and prevention of ROP among preterm infants by high quality NICU care. Care in the delivery room is a gentle resuscitation in room air, avoid ventilation, avoid 100% supplemental oxygen, delayed cord clamping, and maintain and thermoregulation. And in the NICU, avoid 100% unmonitored supplemental oxygen, target saturation ranges to be set, prevent sepsis, promote feeding and good nutrition, avoid unnecessary blood transfusions, and supportive care. In secondary prevention, there is early detection of sight-threatening ROP and urgent treatment with follow-up. And tertiary prevention is the surgeries for stage 4 or 5 ROPs. Next slide, please. Quality improvement. It is to address the gaps in the staff knowledge, poor parental follow-up, and inconsistent care. It enhances the screening rates and timeliness. It ensures the accuracy, standard protocols for imaging, and ongoing training. Expands access to specialists, telemedicine, and AI. And the preventive measures to be taken to prevent ROP. For treatment and follow-up, parent education tracking systems and multidisciplinary collaboration is essential between neonatologists, ophthalmologists, parents. The medical legal documentation. While screening a baby for ROP, all these things should be documented. That is details of the baby, owing to name, IPOP number, gestational age, and risk factors. The date of screening, who has screened, findings pertaining to the zone stage, and further follow-up dates. And what is the plan of action, whether to wait and watch or treat, and it should be treated within 72 hours if it requires treatment. Documentation of parental counseling in their own language, and mention of the follow-up dates in the summaries. Next slide, please. In recent advances, there is a trial of prophylactic oral propranolol that may prevent progression to severe ROP requiring laser or anti-VEGF in infants less than 32 weeks of gestational age. Next slide, please. Innovations in imaging, that is the RETCAM we already discussed about, ultra-wide field retinal photography. It is a new tool for evaluating foveal growth, vascularization, and this has also made telescreening affordable and possible, especially in countries like India or in remote places where ophthalmologists are not available. In artificial intelligence, computer software equipped with AI tools are being developed to automatically detect, grade, and classify the disease, which are helping in training this, triaging the screening programs. Deep ROP is deep learning algorithms of ROP. It differentiates plus disease based on wide angle posterior pole retinal images. And IROP is the detection of vessel severity score based on imaging. Next, advances under research for prevention and treatment of gene therapy and supportive therapies like IGF-1 treatment may help normal retinal vascular development and prevent abnormal vascular proliferation. Omega-3 polyunsaturated fatty acids, GCSF, it is a biological cytokine which increases the leukocyte counts and has shown to increase levels of IGF-1. And vitamin E, an antioxidant, it can be hypothesized to have a protective role in preventing ROP. Thank you.
Thank you, Dr. Poonam, for actually establishing a ground where the further discussion could be made for. I know we have to give you a very short time period of 20 minutes because we wanted the discussion to be more elaborative because we have expert with us. So thank you for covering the vast topic in some 20 minutes and just giving an insight to it. So over to you, Sameer sir, for the further discussion and the expert comments.
Thank you so much, ma'am. Thank you so much for giving me this opportunity. And I'll thank all the panelists for agreeing to bear with me and getting bored. So, thank you, Dr. Poonam, because such an elaborate topic, you have taken it so lucidly. It was a superb and awesome revision. And as soon as somebody says ROP, you remember an ophthalmologist, and then everything is A, B, C, D, E, F, G, H, I, J, K, whatever you say is perfectly fine with me. But the screening is done, and are you happy with it or not? So that's the second part we generally don't see. Screening ho gaya na bas, and that's perfectly fine. It saves me from a kind of legal liability, at least 4 CR. So that's what is the concern right now. So let's start the panel discussion. We have almost half an hour left with us. So I have a lot of time to bore you guys. So we'll start with Dr. Poonam. Dr. Poonam, you mentioned the criteria for ROP screening, which is laid down by NNF, widely accepted. It is pretty much nice guideline. But are there any exceptions in this criteria? Like there are, just to put it in perspective, that do we need to screen term babies for ROP anytime?
Yes, sir. Term babies which actually undergo very turbulent environments like prolonged respiratory support, aggressive ventilation, or babies requiring exchange transfusions, or babies with IVH or any bleeds with severe sepsis.
So
These
these are
babies.
the criteria which are laid down as a kind of expert opinion, which is considered the lowest level of evidence. So can you quote any reference from where if I want to put it down in my unit that yes, which all babies to be screened apart from this criteria. So is there a list available anywhere? Any association? Anyone has published that list? Any idea, Dr. Poonam?
No, sir.
Anand sir, Kedar sir would like to comment on it.
Yeah, I think as you mentioned, as far as the guidelines go, it is best not to follow anything other than the national ROP guidelines. So the NNF guideline is predated, one of them in 2010 and then the other one in 2020. But the ones that the courts are using, because there are judgments in which they quote They don't quote the NNF guidelines, they quote the national ROP guidelines. And those are available. In fact, a lot of the screenshots that Dr. Poonam put are from the operational guidelines. And there it's very simple. It's less than 2 kilos and less than 34 weeks. And there's a easy rule that we ophthalmologists tell the neonatologists. It's called the 1, 2, 3, 4 rule. So that's the first screening. That's 2 kgs, 34 weeks, and between the third and fourth week of life. So that's 1, 2, 3, 4. And that's a nice slogan that you can put out. So anyone outside 34 weeks to 36 weeks, there is a gray criteria where it is on the discretion of the neonatologist. So those risk factors that you're talking about, there are 36 of them that have been published from India, and it goes all the way from shock to fungal sepsis, double volume exchange transfusion. That list is actually there in the operational guidelines. But I think you have the gut feeling that, okay, this baby's had a stormy postnatal course. Again, no one defined stormy postnatal course. So it is best that in your own interest, if you find that the baby has been sick and you know that this is not a normal baby who's term or late preterm, it might as well get one screening done. And that's just being safe.
Okay, great. Any experience from you, Kedar, sir?
Yeah, I think I believe whatever Dr. Anand has said is perfectly correct. Coming to our practice, although most of the babies within the criteria for screening are genuinely the candidate for ROP screening, but yes, we have seen at times, I mean, they have been perplexed with why this child has developed treatable ROP sometimes. So the HJ baby, which may be a little more than 34 weeks of gestation, but with some risk factors, they can also develop ROP. So that should not be missed just because otherwise the child was stable. So
Great, sir. Dr. Anand, generally, as Dr. Poonam mentioned, that's a kind of standard protocol to dilate eyes, or if those medicines are not available, can we use any alternatives?
Nowadays, it's commercially available as the ROP drops. It is iTrop Plus, Tropac P Semi. There are different commercially available ones. It's 2 drops, about 10-15 minutes apart, is most of the time enough. For a dark pigmented iris, sometimes you need maybe a third drop. And as she rightly said, if the pupil is not dilating, it might be because of tunica vasculosa lentis. So don't overdilate, you will cause systemic side effects. Instead, wait for your ophthalmologist to come and see, or you can see directly with your torchlight that there will be neovascularization around the iris, which is called tunica vasculosa lentis. And that's usually a sign of very severe ROP at the back, because rigid pupil itself is one of the signs. So it's commercially available now as ROP drops, so very easily available. Not so much in the pharmacy because it's not a retail product, but all NICUs can usually procure it in batches in bigger cohorts and keep it. So I think it's not a problem anymore. And if you just don't get it, then 1:4 dilution of Drosin, which is available in the ophthalmology unit. So from 10%, you make it 2.5% of phenylephrine and 0.8% of tropicamide if you're using it in combination, or 0.5% tropicamide if you're using it separately. Cyclopentolate is not really required for ROP screening. It can be used during treatment because you want a little more prolonged dilatation, and that's commercially available. I think there is a lot of fear among neonatologists to think that it will cause paralytic ileus and so on. No, it's really, really, really rare. It's probably only in textbooks. We don't see that at all, almost clinically. But then you don't have to use it. You can just use tropicamide and phenylephrine.
And any experience from Kedar sir about babies developing side effects? What I have feel is the improper analgesia, which is creating more trouble than the drug itself. But I would like to hear from the expert.
yeah, thank you, Sandeep. So basically, both manipulation of the eye as well as these cycloplegic eye drop both can cause cardiorespiratory and gastrointestinal effects, which are common, like bradycardias, apneas, desaturation episodes, vomitings. So it is essential to monitor baby during as well as after the procedure. And use of topical anesthetics based on the preference of the ophthalmologist can help to reduce these pain and other side effects. Definitely.
So what do you use for analgesia during ROP screening? I use sucrose, but what do you use, sir?
So we used to use sucrose, but now since it is not available, we are using 25% dextrose and EBM also sometimes.
Great, sir. Anand, sir, most of the screening happens in NICU. You are being called all the time. Kind of what are the main hurdles do you face in NICU? What and kind of if I want to ask the question other way around, what are your expectations from the neonatologist and the newborn unit basically as a whole, from nursing staff and the doctor himself, which makes your visit more comfortable and lucid when you go for ROP screening?
I think pre-marking on the previous day, deciding which babies require ROP screening is the most important one so that no baby gets missed. Then on the day of the visit, of course, coordinate with your ROP team and then dilate appropriately. Dilate about 45 minutes to 1 hour before the screening exam. The dilatation lasts for almost 2-3 hours if it's put normally, so you don't have to time it so perfectly. During the ROP screening, a nurse, if they help our team, or the ophthalmologist in whichever the modality they are screening, just to be around to hold the baby, monitor the baby, then the ophthalmologist or the screening team with the cameras can do their job more efficiently. And of course, we should be very mindful. We, as in the ophthalmologist, should be very mindful about the rules of the NICU. So, in terms of hand wash, the mask, the gowns, I think we have to respect that. And so, moving from one baby to the other, using separate speculum and depressor if required should be done. So, bringing that many instruments or equipment is very important, and not just washing it with soap, because we can be the fomites for transfer of infection. And I think documentation, the findings that are written by the ophthalmologist or the ROP screening team has to be, many times the parents are not available at the time of screening. So communicating that to the parent sometimes has to become the responsibility of the neonatologist or the nurse, because the ROP person may leave having documented it on the card or in the inpatient file. So I think there a little bit of help. I guess, yeah, that's the majority of the things that are required. And then maintaining registers. So what we do in our KidDrop program is we have a duplicate system. So we take one sheet and we leave one in the NICU so that there's enough data for them to call back the mother, the parent after discharge.
Great, sir. Asking us, extending the same thing, Dr. Poonam, as sir said, okay, sucrose or breast milk can be used. Anything apart from that, do you use it for analgesia for in RO during RO? Something like do you use alarm for ROT screening?
So in our unit also, topical anesthetic drops, and we usually use express breast milk and swaddling the baby.
Great. Anand sir, we all are worried in neonatologists that in sick LBW preterm babies, kind of, how early is too early? Because I had an opportunity to meet Dr. Subhadra Jalali, and she, in her own experience, says that, no, I have seen ROP on day one also. So that is the pre-phase, which is, that internal inflammation which is triggering up. So in sick preterm babies, I'm talking about mainly babies who are less than 1 kg and less than 28 weeks. So what do you think that in 1, 2, 3, 4, and kind of how early is 4? So by end of third or fourth week, by 21 days, the one examination has to happen. But in such sick babies, especially with the one with some history of some leaking PV, some history of maybe chorominitis in the mother, what do you feel this baby should be screened how early? As soon as they are stable, as soon as they are sort of amenable for examination, kind of by 72 hours of life or something like that. So anything like that. So how early is too early in sick preterm babies, sir?
There is no too early, but I think we again respect what the neonatologist says. If the baby is extremely unstable, we can push it by a week. We actually had a study in which we compared the standard 3 to 4 week versus one screening before discharge. We did it in 2 government hospitals. We published it in Indian Pediatrics. And we showed that if you did a screening early, you had a 8 times higher chance of enrolling the baby for ROP screening in the subsequent follow-ups, because because the parent now becomes very mindful and cognizant of this disease. You show them the image, you tell them what this disease is about, and they come back. As far as the systemic safety is concerned, these sick babies are the ones who are most likely going to get aggressive ROP. And that usually can occur as early as 10 to 14 days. So it would be safe to say that if you can screen before the second week, somewhere between 10 and 14 days, for a baby who is pretty sick and completely ventilator dependent, maybe temperature sensitive, all of that, a very sick baby inside one of your level 3 NICUs, then between 10 and 14 days you should be fairly safe. Legally you're definitely safe, and as you rightly said, 30 days not to exceed. There is a slogan in the Indian ROP Society which we call 30 din roshni ke, which is of course heavily borrowed from Do Boon Zindagi Ke from polio. Yeah, I think it works pretty well in terms of a legal mandate.
And look, documentation happened. How do you maintain them in IPD papers, and how do you give the same thing to the parents? So do you give original to the parents, the ophthalmologist notes, or and you keep the duplicates, or what's the kind of documentation you use in your unit?
Samir, this is an excellent question in terms of both quality of care as well as medical legal issue is concerned. So first, let us discuss about documentation. What kind of documentation we should have? So right from the beginning, when you start any oxygen therapy or a ventilator or any support which includes oxygen or respiratory support, you need to document the indications, that is the diagnosis, the mode of delivery of the oxygen therapy, that is whether it's a nasal prong, CPAP, ventilator, date and time when you started, the starting oxygen, the target saturations as per unit policy, the settings, the baseline saturations and vital signs, the orders of the doctor, his signature. And when you are delivering the therapy, then you should have the monitoring records of SpO2, continuous pulse oximetry with alarm limits clearly noted, daily charting of the minimum, maximum, and average SpO2s, the FI2 trends in the progress notes, episodes of desaturations and hyperoxias, the weaning plan, the blood gases, the date and time, and the action taken based on blood gas. So also you should have documentation of calibration of your blenders and pulse oximeters, the flow meters, and your compliance, documentation of compliance with the saturation target. You can audit it maybe weekly. So the documentation checklist also includes the screening and eligibility and planning, like who are you going to, as per your unit policy, when the ophthalmologist, what is the first date, what is the planned date for the screening, when you have notified the ophthalmologist, and then when you have counseled the parents, so that documentation in detail regarding why it should be done, the procedure, the follow-ups. And when you are doing the screening on the day, you need to have the date, time, the name of the ophthalmologist, the analgesia used, the how the infant tolerated, whether there was any desaturation, brady, the findings in each eye based on zone, stage, and the plus disease or not, what's the impression, what's the plan, signature of the ophthalmologist, the follow-up and communication details properly documented. If your baby is transferred or discharged, then those details must be reflected on the discharge summary. Follow-up contact details for the ophthalmologist must be provided. We need to ensure that parents have understood about the follow-up screening. So what in my unit we do is we have in addition to the discharge summary documentation, we have a separate referral letter to the ophthalmologist with details written on the paper. Like I'll show you this if it is possible for you to see. I don't know. Is it visible? No. Forget about the background.
Because you blurred your background. No, the background will change and it will be visible.
Anyway, forget it. So what we write is the letter to the ophthalmologist with the address, contact number, referring this baby, a little background of the baby, the gestation, weight, the current weight and current gestation. And if previous reports are there, as you said, original reports we give to the patient. the Xerox we keep it. Hence our NICU is a paperless NICU, so we have all the photographs in the cloud itself in the baby's folder. So,
And
so in
Anand sir,
summary,
do you have any
should,
standard from Indian Ophthalmic Society?
Yes, we do. And in fact, the RBSK and the operational guidelines gives an annexure at the back on what the forms and the collection data sheet should look like. We give a card to that's what's recommended. You're giving a card to the parent and maintaining the log in your record however you want, inpatient, outpatient, because these babies come back.
This kind of standard, this kind of card is available anywhere to download where if I want to start in my unit, sir?
It is.
This kind of ROP card
Yes,
or kind
yes.
of
There
ROP
in the
chart or something like
operational
that?
guidelines, you will find that on the website of the Public Health Foundation of India, or if you Google it, or a part of the excerpts have been published in the Indian Journal of Ophthalmology. And Dr. Poonam has actually put screenshots from there, so I'm sure she has access to that. It's a PDF. At the end, you have all of those annexures. Yeah.
Great, sir. Anand sir, one more thing is that, and Kedar sir, I would like to take a lead on this. That when the baby is sick, you have planned ROP screening, it was date or decided, everything happened. But the ophthalmologist is not available on said date. And the ophthalmologist is not able to arrange locum also, or maybe the routine ophthalmologist who is visiting your place. One ophthalmologist who might be visiting to some remote place goes once in a week. Now he is busy on the same day. Okay, for some whatever, there are so many reasons, and they cannot visit, and there is no other ophthalmologist who visits such kind of remote places. So how do you come out of this kind of a fix?
yeah, that's a very, very important question and situation also, because ROP is a time-sensitive screening. It's a sight-saving intervention. So delays can lead to mistreatment windows and permanent blindness. So both neonatologists and the institute have a duty of care to ensure that screening is done as early as feasible, and any unavoidable delay is documented, communicated, and compensated by alternative measures. So what immediate remedies when the ophthalmologist is not available is to find another ophthalmologist if available. You can obviously need to document that, sign it by the neonatologist and unit in charge. So that shows that you are aware about the screening, there is the intent, and there is a communication and documentation. So if the baby is sick, like unstable, requiring high FiO2s, ventilator, anatrops, etc., then document it. Screening deferred due to medical instability. Risk of procedure outweighs the benefit at this time. Okay. When medically unstable, it is acceptable to defer for a few days, but never without documentation and plan. So you can arrange an alternative. You can have another ophthalmologist, or like Poonam has already told us, the digital cameras, if they are available, you can have a trained technician or somebody trained in unit to take those images and then send it to the ophthalmologist. And in otherwise, in a stable baby, you can even transport the baby to the center, another center where the facilities are available. But communication, consent, and documentation is a must. There are legal implications, and the onus lies on the neonatal care provider or the hospital to screen. So everything, even the courts have ruled that system failure is not acceptable defense, and so it is very, very clear about that.
Cool.
Okay, so that is the minimum documentation to protect yourself medically is you write the due date, reason for the delay, efforts taken to arrange, counseling documented, and next planned screening date. Another option, as Dr. Anand had told me, is to use a 20 diopter lens.
Anand sir.
Yeah, I didn't get you. Your voice is breaking.
Yeah, Kedar sir, you're saying, sorry. Yes, sir, you are saying something about the 20 diopter lens.
So you can have a 20 diopter lens and take photographs, 6-7 photographs, and send it to your ophthalmologist. It will not miss the severe form of RB which requires treatment, immediate attention, usually.
So, Dr. Anand, have you any experience in kind of training a neonatologist or the neonatology fellow in just screening when you are not there? And in short of RETCAM, Are there any other jugards by which I can take photograph for retina?
Absolutely. In fact, there is a DM thesis from PGI Chandigarh that was published probably last year or earlier this year, where the pediatrician and the pediatric nurses have been involved in the ROP screening. Of course, this is through imaging. And in fact, there is a publication from London School of Hygiene and Tropical Medicine with Dr. Ashok Deorari as one of the authors, where many years ago they talk about a paradigm shift in the way ROP screening is going to happen world over. Because the most successful programs have happened when it is led by a neonatologist, not by the ophthalmologist. And the pediatric nurses are trained actually to be part of the screening ecosystem. And that's because affordable cameras have now come. The RedCam is actually a generic name. It's like saying Xerox. It's actually a company's name. But now we have the Indian camera, the Indian ROP camera. There are at least two, or there are two definitely in the market. And then there are Jugaad systems, like you mentioned, which is just a 4 or 5,000 rupee contraption on which you can put your smartphone on top and the regular lens that is used in your ophthalmology department. This is a small learning curve. It's not a great documentation system in terms of a wide field view, but you can certainly get the posterior pole, the macular center, good enough to detect plus disease, as Dr. Poonam showed. And at least you'll know, is this treatment requiring ROP or not? To train a neonatologist or a neonatal nurse to do indirect ophthalmoscopy with a 20 diopter lens, the learning curve is much more steeper. It's much easier to train them how to actually take an image rather than do indirect ophthalmoscopy. So yes, these are all the methodologies. And if you are actually stuck, there are 14 court cases so far, which that I'm aware of, and I keep collecting these cases. And of all 14 have gone against the neonatologist. One of them has gone against the ophthalmologist as well. One of them is a fairly landmark case in which they said that, and as Dr. Kedar very nicely summarized all the things you need to document, the most important thing is that for whatever reason, if the baby is too sick and you can't screen it on time, document it for sure. But the first available instance when you can do the screening, do it. Because in that case, the neonatologist had beautifully documented why it could not be done in the first 30 days, but unfortunately failed to do it when the baby became healthier. And that's how he still lost the case. So I think that's an important lesson we have to learn.
Great. So now we'll be running short of time, so we'll be asking the sort of rapid fire type of question. We'll not leave such an experienced person like Anand sir. Anand sir, those criteria for doing laser and giving anti-VEGF injections, so those are very standard laid out criterias. But still, we face a lot of variation between the choice among ophthalmologists, that some are very pro VEGF, some are very pro laser. So how do you generally decide, and what are the sort of pros and cons when you weigh while giving anti-VEGF injection versus doing a laser?
Okay, so I have to say categorically, and this is well believed, that laser is still the gold standard. Anti-VEGF is not the gold standard. And laser has a more than 97% success rate for favorable outcome if it's done appropriately, adequately, and at the right time. So what is this? What is the indications for ROP laser? Is that if there is a stage 2 or a stage 3 in zone 2, that's when you can do laser straight away without even thinking of anti-VEGF. Where your top indication would be in terms of giving anti-VEGF would be aggressive ROP or any zone 1 disease. So zone 1 disease, as she mentioned, type 1 ROP, which is treatment requiring ROP. If it is in zone 1, then you will prefer anti-VEGF. However, let's remember that the monotherapy of only giving one injection and then becoming completely normal is a rarity, especially if you give it in ranibizumab, which is the other molecule that became popular, which is mostly available in government institutions now because it is DGCI approval. And those drugs give you a recurrence as early as 4 to 6 weeks. So it's not like you gave the medication and it's magic and it's become all right. 6 weeks later, you will probably be doing laser for this baby anyway. However, if you give the older medication, the Avastin or bevacizumab, which came in the beta ROP trial, there are much lesser recurrences, and these recurrences also happen very much later, sometimes 3, 4, 5 months later when the baby is out of the ICU and much healthier. There's a third medication, the Eylea, which is much more expensive, and that the bioprofile exists between Avastin and ranibizumab. So still the number one choice would be bevacizumab, although it is off-label but not illegal, and that is a preferred choice for many ROP specialists in India and across the world. So that I think would be the one. So laser for zone 2 disease, and for zone 1 disease and aggressive ROP, anti-VEGF. The follow-up schedule also will be different based on which drug you use and what indication you've given the drug for.
Great. Kedar sir, have you noticed any side effects while giving this anti-VEGF? And Anand sir, I would like you to follow up this question that while giving anti-VEGF drug or while doing laser, do you always feel that NICU backup should be a must, or you should do all this procedure only in NICU with a backup person involved?
So
Kedar,
the laser can be done anywhere. We can do it in the NICU, in the step-down NICU, in the ophthalmology OR. But yes, we must have a neonatologist, an anesthetist, or at least a neonatal nurse backup. The contrary is when you give an injection, the one place where we would prefer not to do it in is the NICU, because the risk of endophthalmitis is actually higher in NICU because of the sicker environment. That's when we prefer the ophthalmologist's operating room or the OT. So injection in the ophthalmologist's hospital in his operation theater, not in the outpatient, and laser pretty much anywhere. I'm personally most comfortable if I'm doing the laser in the NICU because all of you guys are there to take care of the baby, but not the injection. You can make the exception and give the injection in the NICU, but that has to be a special consent, and these have to be more double precaution in terms of how you do the betadine wash and how you prepare. It's like doing a mini retinal surgery in the NICU. We don't recommend it. It's not part of the recommendations to do it in the NICU.
Cool. Kedar sir, any of your personal experience regarding the side effects of this anti-VEGF injection, systemic side effects?
There is a theoretical actually possibility of suppressing the VEGF level in the babies, leading to damage to brain, lungs, liver, kidneys, but these are not substantiated. But a long-term follow-up data is needed to exactly establish the safety of the anti-VEGF in these babies. Obviously, as Anand said, it is endophthalmitis, which is a rare but potentially devastating complications. Some other complications which may be seen in 5 to 10% of the babies are retinal hemorrhages, detachment, cataract, increase in intraocular pressure, and these are common when you use the combination of anti-VEGF with laser. But systemic side effects are very rare. Lasers are tolerated pretty well that way, but we have to take care obviously of pain. And what we do generally is, in a stable baby who is more mature, we send a trained nursing staff with all resuscitation equipment to the ophthalmologist. They are not coming in our unit for laser. So we have to send the baby there. And whenever a baby who is a little fragile, who requires early laser, then we send a trained fellow or a resident who is trained in resuscitation as a standby there. And we transport, we take care of prevention of hypothermia and hypoxia and all those things. We arrange the oxygen if required for babies in the ophthalmology unit also. So with pulse ox and all, everything.
Great. Anand sir, how long these babies should be followed up just for the ROP? Because I've seen many long follow-up going on just because of some thin rim of temporal avascular retina is still there. And I've seen many of them doing a laser also for the same thing. So how long this baby should follow up during their childhood for developing a refractory error? Or when if the babies don't develop any refractory error, when we should call it a day, when we should stop following them up from ophthalmology point of view?
Okay, great question. And so first, I think the question you asked in the beginning was about the avascular retina. That's a really important entity in the era of anti-VEGF. So it is in fact defined in the ICROP3 classification as 2 disc diameters or more retinal area of persistent avascular retina. That is called clinically significant persistent avascular retina. And if that exists, especially in an eye that has been injected, it must be lasered. When to laser? The guidelines from the Indian ROP Society will soon be out, but I can tell you that one must at least wait till the vessels are in zone 2, or wait for at least 48 to 50 weeks, ideally, post-menstrual age, or you can wait for the weight to increase about 4.5 kgs, because as you know from the physiology, if the insulin growth factor increase the weight of the baby and then reduces the ROP per se and promotes vascularization. Now, as far as how long are you going to follow up these babies? Well, the current mandate is lifelong, because you now have adult ROP sequelae. The baby boomer generation has shown us that those babies who had spontaneous regression of type 2 ROP are 17 times more at a higher risk of retinal detachment as young adults and adults, because their peripheral retina has much higher chances of developing lattice degenerations, snail track degenerations, multiple retinal holes, sieve-like retina, giant retinal tears, retinal detachments. All of it is far more common. They are also more prone to retinal detachments after trivial injury. So, and all of this perhaps happens because there was no one really took care of the persistent avascular retina. Maybe 15 years down the line, we will know the statistics on how we have reduced the incidence of long-term retinal detachment by being more mindful of the persistent avascular retina and treating it on time. But the schedule is, at least the RBSK schedule says at least till 7 years of age. So if you want to go by some government guidelines, it is 7 years of age. You must do the first screening as early as 6 months corrected age, one definitely at 1 year, and then you can make it 6 monthly after that, annual after the age of 3, and definitely up to 7. But we follow up our babies into adulthood and then transfer them to the adult retina department. That's how we've been doing it. And you won't believe the long-term, and it's been published, the long-term sequelae of even innocuous so-called ROP.
Sir, if this kind of laser is such a gold standard treatment, and plenty of time we face problem, you must be struggling in a private practice that finding a technician, finding a machine. Plenty of the machines are on loan. Do you think it's a fruitful investment, and how much will be the investment if I want to establish want to buy a laser machine for my unit?
If you want to buy something for your unit, buy a ROP camera. Don't buy a laser unit. It's not going to be any return on investment, because you will be using it once or twice a month. Even in a busy unit, you might not have more than 1 or 2 babies a week that require treatment. Unless you're doing multicentric NICU care, like in our program, we do about 55 to 60 lasers in a month. And that's because we screen in 170 plus NICU. So it's not going to be return on investment to buy a laser. Buy a camera instead. You'll be much more protected. You can train your nurses how to do it. You can screen on days when your ROP team doesn't come, and you can pretty much be on the top of things, because as neonatologists, you feel many times, I know that everything else you'll have super control of. But ROP screening, you just have to believe, unfortunately, what the ROP specialist has written. And he or she may not be right all the time. But with an image, you can never be wrong.
So, sir, I would request you to write down those Indian modification of those retinal cameras which are available there, which are a little cheaper also. So the details where we can sort of Google, maybe we'll so reach out to you personally for the dealer details and all. But
Sure.
at least what are they called, and approximately how much they cost.
Sure.
Going on to practically the last question. Again, Anand sir, the last comment from your side, that how the AI is shaping up the ROP screening and the ROP treatment, sir.
AI is coming up in a very big way in ophthalmology and definitely in ROP. There are at least 2 groups from India that are developing indigenous ROP profiles. One is in Pune, and the other one is us here in Karnataka. Because ROP now imaging has become such a large part of the screening ecosystem, why not AI? So we have come to a point where we have about a 92 to 94% positive predictive value of a image going into the AI algorithm and coming out with a diagnosis of whether there's disease or not. But what we are trying to do is integrate it with the camera itself. So when you have a healthcare worker or a nurse or anyone, a naive person who is taking the image, you automatically get a a risk score saying that this is a heat map, this is where the disease probably is, and this baby needs to be either followed up or high risk for requiring treatment. And then the triage that the AI system will call will allow you to push the baby into the higher category of the hierarchy in the ecosystem to make sure the baby's either got treatment or followed up or more closely watched based on what you find. And this AI algorithm that we are developing is in fact funded by none other than Government of India. So the Department of Science and Technology, BIRAC, is funding this. So and we will have our first indigenous AI algorithm by the end of the year, if not maybe by Jan. It's almost ready. It's getting validated in the real world multicentric trials as we speak.
Superb. So, Anand sir, Dr. Gunjan, I think we have exceeded already the given time limit. So I'll end my questions here. Thank you so much, Anand sir, for all these insights and your superb experience. Thank you so much for sharing it with us. Kedar sir knows the pain of running a NICU and keeping all the specialists together. I'm in the same boat. Thank you, Kedar sir. He has already, is a good friend and mentor since a very long time. Thank you so much, Kedar sir, for joining in and sharing your experience. We could not ask, involve Dr. Poonam a lot, but that's what to take away. So when you take a superb seminar, then you won't get recognized. So
Samir, your voice is
I'll
breaking.
end
You
here.
can
Dr.
talk
Gunjan,
again.
over to
Your
you.
voice is breaking, Samir.
Okay. Thank you, Samisa. I think your voice got broken in the last and we couldn't hear you. But I still have certain questions. I think we can spare some 2-3 minutes more since we have Anand sir with us. So we can take just advantage of some of the points. One thing is, sir, many of the residents and they did had a queries and we had some direct question. Maybe it's not visible in the Q&A section. One is we get an phenylephrine drops as 5%. So how to make it as 2.5%? Or is it fine if we use it as 5%?
It is fine if you can use it from 5%. It used to be used 5% for a long time, but 2.5% is now commercially available. It is commercially available as semi. So the same drug, for example, Tropta P is the 5% and Tropta P semi. If you specify semi, that's actually meant for infants. Any baby more than about 2.5 kgs in the long-term follow-up when they come, you can use the 5%, but of course 2.5%. You just have to dilute it with a lubricant. Or sterile water for injection. We used to use lubricants, the lubricants like CMC, 1%, 0.5%, any vehicle, basically, any of those eye drops that you guys get as lubricants in any of the pharmacies, you can use that, or sterile water for injection. If you are using sterile water for injection, you must discard the diluent by the end of the day. You can only use it for that day. But honestly, now the semi version is very, very easily available. I think I encourage you all to get that.
Okay. One more thing. We have seen, I will not name the units. We have seen that there are places where the red cam person who comes up, takes the images, and writes the report. Is it fine or it should be validated from the ophthalmologist?
It is absolutely fine. And here I must point you out to the national ROP guidelines. India became the first country to allow ROP screening by using a camera and by using a camera by non-physicians, basically non-doctors. As long as the ecosystem supports that trained and accredited imager, so much more an imager than a technician. And in the ecosystem, there is an ROP specialist who is willing to take on the legal burden of what that technician is writing. You are safe. And it's very much there in the national operational guidelines, so you don't have to worry.
Okay. So in case if there is an institute where the parents could not bear the cost, is there any NGO available who can bear the cost of the anti-VEGF in case if the parents it's becoming a non-affordable for the parents?
I think this is a very local and regional question because what happens in Rajasthan is different from Maharashtra, different from Karnataka. In fact, right now in most of the RIOs, the Regional Institute of Ophthalmology, they are being given free anti-VEGF, the ranibizumab molecule. So that's one thing. That's one option for them to go to the government centers. NGOs, yes, there are. In fact, in the ones that the Regional Institute of Ophthalmology in Karnataka is actually funded by an NGO. So they get their drug from there. But I think this is a one-on-one kind of a situation. One has to establish that ecosystem of who is going to give that kind of money because the baby who needs anti-VEGF is obviously going to require the treatment within 48 to 72 hours. So there's no scope for going around with a begging bowl then. One has to have your donors or crowdfunding sources ready before this situation even arises.
Okay. So taking into consideration bevacizumab versus ranibizumab, which we have already discussed by you, bevacizumab is something which comes as a multi-dose vial, as far as I know, and
Correct.
the biggest
Which
disadvantage.
is why it is difficult in private practice to make it available. Because honestly, the multi-vial, if you don't have use case for using the rest of them within that period of time, you're pretty much buying the whole vial for just one baby. And that's not going to be working out financially for most private practitioners. And that is a big advantage if you're working in a larger hospital or an institution or a medical college, because the use of Avastin is so much in adult retina that you can definitely have use for the entire vial over the few days. So that the way it is aliquoted, the procedure is extremely well established by the Vitreoretinal Society of India. One has to remember that in 2016, Avastin was banned because of some infections that occurred in adults in some North Indian states, and then the government reversed the ban, which I think is, if you speak to lawyers, it's a very, very strong point in favor of Avastin. But during that reversal of ban, there were certain guidelines laid down on how this drug has to be used, aliquoted, stored, preserved, so on and so forth. And that's available on the Vitreoretinal Society of India website. And as long as your ophthalmology team is aware of that and following those guidelines, there's absolutely nothing to fear.
And we have seen in many of the reports when the retina become completely vascularized, especially in the preterm infants, we have seen the ophthalmologist writing the fact that review after 1 month for retinoscopy.
Mm-hmm.
So,
So this is what we call long-term follow-up for the sequelae, as mentioned, or the list of that is there in the ICROP 3 classification. The earliest one can do retinoscopy to make to genuinely to check whether there are any changes would be the third corrected month. Most centers in India do it at 6 months. In fact, few of them do it at the end of 1 year. But we find that by 6 months, many of them have early myopic shifts, even if they have not had ROP and even if they've not had treatment. Just by the virtue of being a premature baby, 700, 800, 1100 gram baby, there is a chance of turning myopic. In our own center, we do it at the third corrected month. There are about less than 5% of babies who turn myopic that early. A majority of them turn myopic in the first 2 years, but from 6 months, 9 months, and 1 year, much more common for that shift to happen. But exactly 30 days later, I don't know. It may not serve any extra purpose except for the fact that the parent is made aware of this thing, and then the next checkup can perhaps be at a more longer distance.
So these are from my end, sir. Sameer, sir, any closing remark from you, sir?
No, thank you so much. I thought I sort of got disconnected in between. Uh, but thank you so much, Anand sir, for such a vast experience. You have huge amount of knowledge and experience in the field. Thank you so much for sparing this valuable time.
Thank you.
And Kedar sir, my
Just
old friend since a very long time, and he shares my pain of running an your own unit. So thank you, Dr. Kedar. Thank you, Anand sir.
Thank you. I just want to say now the recent advances that we are able to take the tears of these babies during the first screening and second screening. And based on the biomarkers we find in these tears, we're able to predict whether the baby is going to get disease or not in the subsequent screening examinations. And that is a completely and indigenously developed biomarker here, right here in India. And that's something that might just change the way we are screening in the rural areas especially. And finally, I want to thank Dr. Gunjan and the entire NNF team. I'm an NNF Karnataka member, not a very active one, but part of the job profile that I have with ROP. And I just want to say that we are so grateful to y'all as a group of neonatologists, because y'all are the most compassionate physicians that we know. And there is a slogan in the Indian ROP Society that when we say no ROP, it means that the neonatologist N and O ophthalmologist have to work together. So if we work together, only then there will be no ROP. So thank you very much for inviting me. This is always a learning session for me, and I love interacting with neonatologists. There's always so much to learn from you all.
Thank you for joining, sir, and thank you for accepting this invite. We are grateful to have you. Thank you, Kedar sir, for sparing time and for accepting the invite and be a part of this session. And always, I would not thank Sameer sir because he is a part of NNF and he's a part of the National team. But thank you.
So thank you everybody.
Always,
Sameer
always,
and
always a pleasure.
Thank you so much.
Thank
Thank
you,
you.
ma'am. Thank you, sir.
Bye.